Intraoperative fluoroscopic angular metrics for optimizing alignment in occipitocervical fusion for craniocervical instability. We present the case of a 38-year-old female who presented with the chief complaint of movement-associated neck pain and headaches. She stated that she had a 5-year history of these symptoms and that they were also associated with intermittent dexterity issues and upper extremity paresthesias. She went through multiple conservative measures without relief, including physical therapy, chiropractic manipulation, and various oral medications. She ultimately was recommended to undergo a hard collar trial for 1 month and noted complete resolution of her symptoms over the course of this period. On physical examination, her mental status and cranial nerve examination was non-focal, and she had no sensory motor deficits on confrontational examination. There was no evidence of ataxia or gait imbalance issues, negative Romberg sign, and no upper motor neuron signs. She also had a negative Sperling sign and negative Lermite sign. She did have pain-limited active range of motion with rotary and flexion-extension movements of the head. She had no other relevant past medical, surgical, or social history. T2-weighted sagittal and axial MRI demonstrate preservation of the normal cervical lordosis without any significant disc herniation resulting in cord or foraminal compression. However, at the cervical medullary junction, she was noted to have 7 mm downward descent of the cerebellar tonsils through the foramen magnum, consistent with the type 1 Chiari malformation. Crowding of the cervical medullary junction is better appreciated on the axial cut. AP lateral and flexion extension standing X-rays demonstrated straightening of the normal cervical lordosis. There was otherwise preserved alignment without any significant degenerative features such as osteophytes and/or traumatic fractures. There were no overt radiographic signs of dynamic instability on lateral X-rays. However, the patient did relate significant symptom improvement when placed in external orthosis. Based on the constellation of the patient's history, physical examination, symptomatology, and imaging findings, a diagnosis of type 1 Chiari malformation with craniocervical junction instability was made. This was primarily categorized due to the subjective nature of her symptoms and resolution with a hard-collared trial. At this point, given the patient's extensive diminishment in her quality of life and failed years of conservative management, different surgical options were discussed, including the risk and benefits of each. Specifically, the procedures that were considered were a suboccipital craniectomy, also referred to as a Chiari decompression, that is either performed as a standalone procedure or in conjunction with an occipitocervical fusion with instrumentation. The OC fusion could be either performed concurrently during the same procedure or in a staged fashion if there was failure to relieve symptoms with a decompression alone. Extensive discussions include a 50% loss of head movement with OC fusion, in addition to the risk of hardware failure, pseudoarthrosis, and distal junctional pathology, any of which may require additional surgery. The patient and family ultimately opted for the combined Chiari decompression and OC fusion, and informed consent was provided. When performing OC fusion concomitantly with posterior fossa decompression, there are a number of critical surgical considerations. First, performing the suboccipital decompression and C1 laminectomy, when indicated, is typically facilitated by a flexed position, which is physiologically incompatible with the final position required for the OC fusion. Different qualitative, intraoperative imaging findings can aid in achieving alignment during each stage of this type of procedure. When the patient is placed in a flexed position, the neck folds become apparent and the eyes are aimed further towards the feet than would be considered for direct line of sight. On live lateral fluoroscopy, there is also constriction of retromandibular space and the hard palate forms an acute angle with the upper cervical spine. With the Mayfield locking mechanism released, the head can be gently extended back to neutral, noting loss of neck folds and that the eyes are looking straight down perpendicular to the floor. On live fluoroscopy, there is reconstitution of the retromandibular space by moving the head to neutral position, and the hard palate forms a near 90-degree perpendicular angle with the upper cervical spine. However, these qualitative individual assessments are not always reliable. There may be variations in anatomy, subjective assessments of radiographs, and difficulty with gross facial visualization under the drapes intraoperatively, which can result in malalignment. Previous studies have explored the utility of various craniocervical metrics in predicting post-operative complications. The OC2 and OEA angles have been shown to correlate with the narrowest oropharyngeal airway space and clinical outcomes following OC fusion in this respect. The OC2 angle is approximated by measuring the angle from the base of the occipital bone to the hard palate, or more commonly known as McGregor's line, and the line measured from the inferior endplate of the C2 vertebra. The OEA angle is measured by first drawing a line from the external acoustic meatus to the midpoint of the C2 inferior endplate. The intersection between this line and McGregor's line forms the OEA angle. A previous report found that 28% of patients whose OC2 angle was flexed 3 degrees or greater in comparison to the preoperative position developed new symptoms of dyspnea or dysphagia postoperatively following OC fusion. In another study, 18% of patients whose OEA angle was decreased by an average of 12 degrees developed new postoperative dysphagia, and this angle was found to be more strongly correlated with the narrowest oropharyngeal airway space than the OC2 angle. In our patient, the OC2 angle was 8.4 degrees and the OEA angle was 85.4 degrees. We consented her for a suboccipital decompression with duroplasty and bilateral tonsillopexy and an occipit to C3 posterior arthrodesis with instrumentation and iliac crest allograft. Our goal was to use the OC2 and OEA angles to guide positioning during each stage of the procedure. The procedure began with the patient positioned prone in a flexed position with neutral rotation. Chiari decompression was performed in typical fashion and has been previously described in detail by other authors. C2 pars and C3 lateral mass screws were placed using low-dose intraoperative CT and 3-dimensional computer navigation. The occipital plate was carefully positioned above the craniectomy site, and again navigation was used to size and place the occipital screws. A second low-dose intraoperative CT was performed to confirm appropriate placement of all screws. For clarity, we show the patient's preoperative OC2 and OEA angles and how the patient was positioned initially for the first part of the procedure just described, prior to any head position manipulation that would occur under the drapes. Intraoperative fluoro after screw placement demonstrated an OC2 and OEA of 6.1 and 79.1 degrees respectively. With the Mayfield locking mechanism unclamped, the head is slowly extended to neutral to attempt to reach the optimal angles. After initial manipulation, the OC2 and OEA angles are still not within range of the target numbers, with the values of 18.5 and 90.1 degrees respectively. After a second round of minor manipulation, the subsequent position reveals OC2 and OEA angles of 9 and 87 degrees respectively, which are within range of the optimal angles. With this position locked in, the remainder of the fusion is performed by placing bilateral hinged rods and wiring an iliac crest allograft to augment bony fusion. The final construct is shown here. Postoperatively, the patient was ambulating and tolerating a regular diet on post-op day 1. She was in the hospital for 4 days and then discharged home. There were no post-op complications. Postoperative standing x-rays revealed mild reduction in the OC2 angle, which ended in a delta of 1.1 degrees from the preoperative target. The OEA angle slightly increased and ended up 2.9 degrees from the preoperative target. 6-month imaging follow-up demonstrated maintenance of both neutral cervical alignment and the OC2 and OEA angles, which were 7.4 and 84.1 degrees respectively. There was no evidence of hardware loosening, pull-out, or fracture, and MRI demonstrated adequate decompression at the cervical-medullary junction. The patient reported complete resolution of her preoperative symptoms and no complications at the 15-month clinic visit. The OC2 and OEA angles are reliable objective surrogates to achieve optimal alignment during procedures requiring concomitant suboccipital, upper cervical decompression, and occipitocervical fusion. These measurements can be obtained and measured quickly intraoperatively on lateral fluoroscopic images and facilitated by head movement in a single plane, flexion, extension, by manipulation of the Mayfield head clamp locking mechanism. Further cases from our group using this methodology are ongoing and require further study. Future reports may also incorporate other reported measurements used in predicting OC fusion failure, such as the narrowest oropharyngeal airway space, in increasing the accuracy of achieving desired post-operative alignment goals in these complex cases. These metrics and methodology can also be applied for other indications for OC fusion, such as craniocervical traumatic fractures, tumor instability, and inflammatory arthritides.